This is another edition of the PEDro World-Wide Journal Club. The topic for this journal club is frailty. And we're very, very lucky to have Niki Fairhall here to tell us about her research in frailty. And if you haven't already, what you should do before listening to this Worldwide Journal Club is to listen to the short recording that Niki has made that summarises her study and its findings. What we're going to do firstly is all to introduce ourselves, and then Niki will tell us more about the intervention that was in her study. So I'm Simone Dorsch, and I'm on the Education Training Committee of PEDro. I'll hand over to Niki to introduce herself.
My name is Niki Fairhall. I'm a physiotherapist, and I work as a postdoc research associate at the Institute for Musculoskeletal Health at the University of Sydney.
Sandeep.
I'm Sandeep Gupta. Like Simone, I'm on the Education and Training Committee for PEDro. I'm the head of physiotherapy at Balmain Hospital, which is a small subacute hospital in Sydney with aged care rehabilitation as well as general rehabilitation. And one of, I guess, my former hats was on the frailty task force and executive for the Agency for Clinical Innovation in New South Wales.
Vanessa.
My name is Vanessa Jessop. I'm a physiotherapist in Perth, Western Australia. I divide my work time up a little bit, so private practice, home visiting, working with people with gerontology and gerontology neurology. I also work as a clinical supervisor for our fourth year students on their clinical placements in gerontology and neurology. And I'm part of the WA team for the National Ironbark Project, which is an Aboriginal and Torres Strait Islander healthy ageing project.
Thank you. And Adam.
Hi, I'm Adam Wilkes. I work at Long Blue Mountains, which is a not-for-profit organisation in the Blue Mountains, west of Sydney. So we work with Commonwealth Home Support Program clients, the over 65s, mainly running exercise programs, trying to keep them doing strength, mobility and balance long term.
So to start with, Niki was going to give us a bit more detail about the intervention that was used in her study.
So in the video that you've hopefully watched, I talk a lot about the intervention and how it was tailored to the individual participants based on two things. First, it was tailored based on the frailty criteria, which of the 5 frailty criteria they met at baseline. And secondly, we also did comprehensive geriatric assessment, and based on the problems we identified there, we also targeted those problems with the interdisciplinary team. So the elements that were most interesting, I suppose, or most apt to physiotherapists, relevant to physiotherapists, were first of all the case coordination. So the physiotherapist took on the case coordination role and facilitated the case conferences in liaise with the rehab specialists, geriatricians, dietitians, nurse, and also the service providers. The other thing the physiotherapists did was they implemented 10 home-based physiotherapy sessions over the course of a year. These physiotherapy sessions were front-loaded, so there were 5 sessions in the first 3 months, and the next 5 home-based or home visits were in the next 9 months of the 12-month intervention period. These home visits were 45 to 60 minutes duration, and they were in the participants' homes. 2 of the interventions were a bit different. 2 of the home visits were different. They targeted the participants' self-selected participation goals. We asked people, what do you want to be able to do in terms of your mobility in 12 months? We helped them set SMART goals around that, use the goal attainment scale to judge how well they did, and we really worked with them on 2 specific sessions to meet their goals. The other 8 sessions, we addressed the slowness, weakness, and low energy areas of frailty criteria. And to address these, we taught an exercise program called the WEB, or Weight Bearing Exercise for Better Balance program. So this is a program that was designed after the systematic review, trying to find out what type of exercises are going to help people improve their mobility, improve their balance, and stay on their feet when they're older. The intervention was tailored to people's impairments, prescribed 3 to 5 times a week, And we reviewed and modified it regularly depending on how they were progressing. So in order to get a picture of this briefly, some of the main types of exercises we prescribed were balance exercises and strength exercises. The balance exercises, we had three main pillars. First of all, we got people in standing and we got them to reduce their upper limb support. A lot of these people were frail, they held on to walking frames or furniture walked. We get them to let go of the frame with one hand, get them to let go with two hands, and then we got people moving their feet together, narrowing their base of support. So moving feet together, standing in tandem, standing on one leg, progressing to stepping. And the third thing we did was got people moving their center of gravity. So whether it was moving their feet and tapping in different directions or stepping up onto something or reaching to the side, and then we added mental load as well. So we really tried to get people to challenge their balance in a safe way, in a safely set up home environment. In terms of targeting strength, we used functional movements and we added weight as best we could in the home environment. It was often using body weight. And then if we could, we'd progress to a weight vest or weight belts. An example of using body weight would be doing repetitions of sit to stand. So we get people standing up from a chair, we'd progressively lower that chair, or get people to take their hands away and just use body weight without pushing up. As people got better, the chair would get even lower, or we might add a weight vest or change foot position to make it even harder to stand. Likewise, we'd do heel raises or step ups and change the environment in order to progress it and make it more difficult and do that task specific strengthening that way.
Sounds really challenging and fantastic to have frail elderly people doing really challenging, very specific exercises too.
I think that's the challenge in the home environment when you don't want people to fall when they're doing the interventions. There was a lot of environmental setup, a lot of involving families and carers when we could as well, so people could do it safely.
Niki, I was just wondering, with your, I guess, presentation, the summary of your research, you talked, I guess, about the primary research outcomes, so the frail scale, the short physical performance battery and gait speed. Just now you were sort of speaking about balance interventions and falls. Were there any secondary outcomes that were measured like falls or anything else?
We did measure falls. Yeah, there was zero effect on falls. There was no between group difference in falls, but we wouldn't expect that. And we had, I think, 241 participants in this study, and we were powered to detect a difference in frailty between the group. We weren't powered to detect falls. We would have needed about 520 participants to detect a 30% between group difference in falls. So even if there wasn't a difference in falls, but if there was a difference, we wouldn't have picked it up. And saying that, this study did reduce some risk factors for falls. The intervention group at 12 months was significantly stronger at quadricep strength. They were faster, their mobility was better, their postural sway, which we know is also a risk factor for falls. Postural sway was significantly better in the intervention group than the control group.
That's good. Yeah, Niki, I was also wondering, with individualization for the study, obviously it's a broad study, lots of people getting, you know, the 10 physio sessions. How did you find like tailoring it further to those individuals when they had different risk factors or different barriers? Yeah,
it was a really good study to be a part of, being a research physiotherapist, because you did get to really individualize it to the participants. It was when we set their participation goal at baseline before we randomized them. So we didn't know if they'd be in the interventional control group. And we said to them, is there anything in terms of your walking you'd like to be able to do that you can't do now? And the answers were great. I want to be able to walk to the letterbox on a rainy day. I want to be able to get to church. I want to be able to look after my grandchildren after school on a Tuesday. Yeah. And we really use those goals to help structure a lot of the intervention. In those two sessions I mentioned, where we looked specifically at the participation goals, we could really look at what are the barriers to these goals and go back to the impairment level for what's stopping people. Is it balance, is it strength? But also we could look at equipment and family involvement, environmental issues to try and help them reach their goals. And I think that really helped get people to buy into the intervention, and it really helped explain why people needed to do the balance exercises and the strength exercises as well, because they could help in the big picture and meet these big picture goals. And it was great. So we measured the goal attainment scale, to ascertain whether the intervention did help people meet their goals. And it did. At 12 months, the odds of meeting people's goals was twice as high in the intervention group compared to the control group. And that was statistically significant.
Yeah, that's affirming, isn't it, for a lot of clinicians, because they're doing that already. And just to, say that that's a good thing to keep doing, and we get a lot of bang for our buck with that part of the intervention.
Yep.
And Niki, did you find that given the success of the program and achieving those meaningful outcomes alongside the older person, and the challenges we have around on setting up and establishing and maintaining ongoing programs of this nature, did you find that there was an uptake or an interest from others involved in the program, other health professionals, to take this to their organizations and look to a wider service delivery field?
I think the dietitians, quite like the model. They were being referred people who were frail, and then has sort of a support team around them. When we were identifying people who might need nutritional intervention, they would prescribe supplements or maybe Meals on Wheels, meal delivery services if people weren't getting enough or adequate nutrition. And because there was a whole team involved in delivering this intervention, the people who were in there more often, we could follow it up. And the physiotherapists were in the house a lot. We were talking to the carers about the exercises. So we would be also reinforcing those nutritional issues. And so it was a lot of teamwork, and we were all aiming for the same thing, to reduce frailty, which needed a focus from the dietitians as well as the physiotherapists.
We know that it can be challenging for folks to continue with a program or to adhere or engage in the program. And certainly your research gives us some really good ideas in that space and what the outcomes were. Were there other adherence challenges along with exercise, but across with the other disciplines? And what did you do to try and improve that, if there were?
Oh, the adherence was actually not very good. So at the end of the intervention, we retrospectively, which was not the best way to do it, we retrospectively thought, what proportion of the intervention that was prescribed by the rehab specialists, the physios, the service providers, the dietitians, what proportion of that prescribed intervention was actually done? And was it 0%? And for some people, they did nothing. None of the intervention was carried out. Was it 1 to 25%, 26 to 50%, 50 to 75, or 75 to 100% of the intervention prescribed did people actually do? Now, the median amount of intervention was that 25 to 50% of the prescribed intervention. And despite that, the intervention reduced frailty and improved mobility. And I think if you're thinking about this group of people, these were frail older people. Their average age was 80, 83. Majority walked with a walking aid. And they were in and out of hospital a lot. People had social frailty. There was housing issues. Their spouses were having trouble. Their carers could no longer care for them. A lot of them went to hospital or had their chronic medical conditions become an issue. And so it would be very unrealistic, I think, in this population to think that they would be able to carry out a 12-month intervention program with perfect adherence. One of the benefits of the intervention was that we would catch them when they got out of hospital, or catch them when they were over pneumonia or a UTI, and pick it up again as a team. We did do a lot of things to try and improve adherence. I know from a physiotherapy point of view, we really trying to engage the families and carers. We used the goal setting I was talking about before. We had diaries, we had magnets on the fridge that were bright yellow saying, have you done your exercises? We got people doing their sit to stand while they were during the ads and TV. Every time their poor sons or daughters called them, they had to remind them at the end of the phone call to do their exercises. So we did a lot to try and improve adherence, but it was still an issue. But in saying that, I think what was really positive is, despite that, there were still gains made. And if we look at some of those graphs that are in the brief presentation I did, it shows that if people adhered for sort of over 40 or 50% of the prescribed intervention, then they made gains in terms of their frailty and their mobility.
Yeah, and that was quite interesting for me to see, Niki, when I watched your presentation and looked at the paper, that 40%, because sometimes we might be thinking, oh, we've got to aim for, 70, 80, 90%, but to see we could actually have meaningful change, and perhaps what many of us, or at least for myself, was considering a bit lower, was really positive to see.
Yeah, and I think it's realistic. It's the realistic clinical picture.
Yeah, and it also means that when we engage with our clients, patients, about exercise or interventions, that we can actually say, look, if you can do this at least 50% half the time, then you're going to get a positive outcome. And obviously, your study also showed that if you did it a bit more, then you'd have a more positive outcome. But that's sort of the minimum, and I think that's really good from a educational point of view for not only patients but also their families, so that they know that they don't necessarily need to guilt their family member into doing the exercise all the time, or they themselves as a patient don't need to necessarily feel guilty if they miss a day, as long as they're trying to do about 50% of the intervention.
And saying that it was a big intervention, so 50% of a big intervention was still quite a bit. They still had to do quite a bit. If you're not prescribing much, then 50% is not much. But as Sandeep mentioned there was a correlation between people who did more and adhered more, the outcomes were better.
Yeah.
So more is better, but it's not all or nothing.
Could I just ask a question as well? Because in one of the graphs in your presentation, you also showed that I guess the control group also improved, but obviously not as much as the intervention group. So I'm assuming that the control group still got some usual care kind of, support services and all those type of things post-hospitalisation like they normally would. Would that be accurate?
So there are two things to think about. The first was most of the people who were entered into the study had been recently discharged from hospital. So we would expect them to make some gains once they got home and recovered from that acute event. So the control group's mobility, for example, did improve over the first 3 months. But then what happened over the next 9 months, it got worse. And the second thing to think about is in the area that the study was conducted, it is quite the baseline level of care from GPs and community service providers and community allied health is good. It's quite an affluent area of Sydney, and the baseline level of care is good. So those participants in the control group still got the usual care provided in quite a supportive environment.
That brings up some really interesting issues around service delivery. Because like you're saying, if it's really not that first 3 months, but the next 9 months that it made a big difference, whereas a lot of our services are set up for a short delivery of service and then maybe not anything more ongoing. So I guess I'm really interested in everybody's thoughts about what the implications are for their different types of service delivery.
I might start being, I guess, predominantly based, and then we can, I guess, move into, I guess, what Vanessa and Adam from a community point of view think. So I guess if we take a step backwards in regards to frailty, there is evidence to show that people that are frail are more likely to present to hospital, which is what Niki said. There were several representations during the course of the study. If they do have surgery, for example, they're more likely to have complications. They're more likely to suffer delirium if they come into hospital. They're also more likely to end up in residential aged care or nursing homes, depending on what term you want to use. So all of these things happen if you're frailer. And so therefore, I guess if we can intervene as early as possible, then that's important. And obviously Niki's study shows that if you do intervene as a multidisciplinary team, then you can have really good outcomes. And this is in the community. But I guess if you can start by, and I'm assuming, Niki, and you can correct me if I'm wrong, that the frailty was measured in hospital as opposed to in community, or?
No, it was in community. So once they'd been discharged, they were recruited. Okay. So they were out in the community when they were at baseline. They were frail at baseline.
Yeah. So I guess from a hospital-based point of view, you know, if we can at least assess them earlier, then those interventions might be able to be started earlier, rather than necessarily relying on the GPs, because the GPs are obviously quite busy. So at least the interventions can be started earlier, and therefore they can be progressed into the community. So even if we start early in hospital, and you can do some stuff in hospital, it is difficult, but nonetheless you can do balance related stuff. You can do body weight supported resistance-based training kind of interventions. From a physio point of view, the dietitian can be involved in regards to nutritional input and things like that. So then it makes it, I think, easier to then transition. Well, I hope it's easier then to transition into the community.
I think, yeah, there's so many points in it that being so true, Sandeep. And for me, when I'm looking at this service review, looking at Niki's research, looking at the research that's out there, the resources, the literature, if we're really committed to improving the care and looking for meaningful outcomes for, in this case, the older person, either at high risk of frailty, pre-risk or pre-frail or frail, we really have to take an across care continuum perspective. And certainly in Australia, and I'm sure in other parts of the world as well, that's become really quite front of mind in many ways, in a lot of the certainly community and aged care spaces, looking at interfacing issues between health and aged care, health and disability, disability and aged care. So it's across that care continuum. The raising awareness and the identification is critical. As you said, Sandeep, it's just so critical, so that that person has the best opportunity to be moved along in an appropriate, timely manner along a certain care pathway. And then clearly we've seen it in other programs, and we've seen it in our own practice. The research is clear. It's integrated, coordinated approach. It's multidisciplinary teams, and that leads us to some of the structuring how systems issues around workforce, right knowledge, right skills mix. And it's really, I suppose it's really looking at how we can then support these teams, support these programs with good communication pathways. And again, I think we so often see where a program is successful when it's kind of held these things as core. And when we've seen some of these challenges around particularly, say, communication pathways, or we haven't engaged in shared care planning or shared decision making. So vital also in that adherence space Niki spoke to us about. It really makes an enormous difference. You touched earlier on the hospital and the discharge and possibly getting in that early stage, Sandeep, as well. And certainly I know here in Perth, one of our major hospitals in late 2020 implemented a frailty rapid access clinic. So referrals for people, so obviously criteria, referrals for individuals to that clinic have access within 1 week of a geriatrician, comprehensive geriatric assessment, multi-dis assessment included. It's an outpatient service, but also able to provide service through telehealth and in-reach home visiting with allied health. And it starts to, it sits alongside and works alongside the Falls Clinic, Memory Clinic, and Continence Clinic. So I think that's a lovely example of where we're raising awareness, getting the identification, moving the pathways through. One of the prime aims of that clinic is reducing those acute hospitalization admissions.
I just wanted to make one comment that 10 interventions over a 12-month period is actually not that large. But particularly, five interventions over 3 months. And I think we as physiotherapists sometimes want to try and see patients once a week or twice a week. I guess this particular study shows that you don't have to, intervene as much as sometimes what we think we need to. It isn't that costly. And I think, Niki, you touched on the fact that economically it was cost effective.
Yeah, and the very frail people, so those who met 4 or 5 of those 5 frailty criteria, at baseline, it was cost saving and cost effective. And overall, in all the participants, the cost for one person to become no longer frail, for one person to transition out of frailty, was 16,000 Australian dollars. So 12,500 US dollars at 2011 prices.
You know, if we're finding that 10 sessions over a year is doing a really good job, and it really speaks to that coaching model as well, of, you know, helping people to learn rather than, you know, feel like you have to be there the whole time. And so, yeah, I think people in this bracket, you know, they're still very capable of learning and becoming lifelong exercisers. And yeah, sometimes we have to be a bit more, it's hard because we always want to see things happen overnight, but sometimes the slow changes can be more sustained. And, you know, that seems to be the case in Niki's study, where like some of the changes were manifest after about 12 months rather than 3 months. So, you know, sometimes the long game can be helpful. Absolutely.
I think maybe what we should do now is as a bit of a summing up, should we go around and say what we think the biggest sort of take-out message for our clinical practice is? One, if you can, it's a bit hard with there's so many, but what the biggest one is for you. Can we? Well, do you want to tell us what you think the biggest one should be, Niki? And
frailty is reversible, and as clinicians we can intervene. And I mean, frailty, if you're frail, the risk of hospitalization, institutionalization, falling, death is all increased. And we know that with a 12-month intervention with an interdisciplinary team, people can become no longer frail. And it's huge.
Yeah.
And look, I agree with everything that Niki said. I'd say obviously the identification of frailty is probably one of the key things. So if you don't know somebody's frail, then you can't really provide some of these interventions. Although that being said, you know, if they're doing a comprehensive geriatric assessment, they'll pick some of this stuff up. But as we're talking probably predominantly to physiotherapists, and in terms of physiotherapy, we can also identify people that are frail using either the cardiovascular health study or the Fried phenotype. You could use the frail scale, so the FRAIL for frail means fatigue, resistance, ambulation, illness, and loss of weight. So those are probably the two easiest, along with, I guess, the clinical frailty scale, which is a 9-point scale. So those are probably the three easiest methods of identifying somebody that is frail for us as therapists. Some of the other ones are take a little bit more time, whereas these take less than 5 minutes. So, you know, it's not too onerous to try and, I guess, identify somebody who may or may not be frail, or even pre-frail, to be able to intervene even earlier. So that'd be my take, would be the identification first, and then providing the intervention that Niki's so eloquently described earlier.
What about you, Vanessa?
Oh, I was going to absolutely say the combination of raising awareness and the identification. I mean, that identification, everyone watching this now and joining us in this conversation can take this away and implement it immediately. And then just simply add it to their letters to the GPs, add it with some appropriately worded recommendations and so on. It's an immediate takeaway. I also love the fact we know frailty is a dynamic state. It's not a static state, so we can move through in and out. And I would love to see the same way that we've had the anti-ageism campaigns in more recent times, particularly in and around the Royal Commission here in Australia in that space, that we do start to raise that conversation around the barbecue, that we can very easily and comfortably refer someone to a resource page, play around a bit with the words. Most people are not too happy to sort of just see the frailty one front and center, but healthy aging and frailty was used in a study in New South Wales or in a program there. We'll find what works in our communities. And then we can direct people the same way we'll direct people to resources about osteoporosis or vitamin D and sunlight or Parkinson's, you know, Western Australia website, that these become more socially not accepted, but we raise the awareness, and in so doing, we raise acceptance and understanding. We take away some of the negative or stigma connotations from that. And then we support people themselves to seek and become more engaged in their healthcare. So awareness, identification for me, yeah.
Yes. Yeah. What about you, Adam?
Yeah, so maybe I can go into treatment from there. So yeah, I think what what Vanessa was saying about the one-to-one relationship and the therapeutic alliance, I think, and what Niki study said, when you can drill down a bit and find those individual things that they're wanting to overcome, and giving that message of like it's a good message that you can overcome some of this stuff. And just taking the time to try and link that for that person and say, look, if you do this, this can be, you know, where you can get to, and it doesn't take as long as you would think. So yeah, just giving that really positive, hopeful message that things can be done, and every little step, even if it's a small step, will matter.
Yeah. Yeah. Okay, so well, fantastic messages there. But we need to identify it. We know we can do things that will make most enormous difference to it. And we need to kind of get that message out there that it is possible to make an enormous difference, especially with this kind of very multidisciplinary approach addressing sort of problems across multiple levels, but not with a hugely intensive or costly program. So it's just extreme importance that we get that message out there that such a difference can be made without anything particularly whiz bang or millions of dollars. So yes, yeah. So a very big thank you to Niki for presenting her research, and to everybody for all their very valuable inputs from many years of clinical experience in the room here. So thank you very much, everybody.